right, thank you so much. Thank you, Roman. Thank you, Dr. Krishnan. It's just such an honor to be here. To have been, Dr. Krishnan's fellow was just the greatest thing that I've ever done. So I'm very lucky to be here. So we're going to very quickly go through some data about iliac artery interventions. Every time I give this talk, I go way over time, so I'm going to try to keep it very simple. But stop me if anyone has any questions. I have nothing to disclose, unfortunately. If anyone has any opportunities, I'll be back there. And we'll start with a case. So a really nice guy, 68-year-old, all the risk factors, came in with really debilitating claudication, both in the calf and in the thigh. He'd had prior interventions, didn't know much of the details. They'd happened in an OBL out of state. Had some, his pulse exam was diminished and had some non-invasive imaging that basically just said severe diffuse PAD bilaterally, which is not all that helpful. So after a bit of a workup in the clinic, we ended up bringing him for an angiogram. And you can see on these iliac pictures, so he's had a prior intervention in the right common iliac with possibly some proximal edge restenosis. And then the left common iliac, he has a significant lesion there. In terms of runoff, he has some moderate SFA disease, nothing too scary. He's also had prior interventions on the bilateral SFAs. So, he was clinically indicated for an intervention, and we have the angiogram that we just got. So now we have to make some choices. And one of the great things about endovascular interventions is you have so many choices. You can be very creative when you're doing these interventions, and you have choices for every challenge that arises. So specifically for iliac interventions, you have to make the decision of access, so the size, the laterality. You have to decide what crossing system you're going to use, what diameter wire. You have to decide whether you're going to image, and I think after what Shreya said, probably most of us would say, yeah, we want to image. You're going to have to decide if you can or should use any adjunctive devices, and then you're going to have to decide your destination therapy. And there are branch points along each of these decisions that you can make, and that's part of what makes these interventions so much fun. I will just remind us that iliacs are not SFAs, and this is not a very surprising slide, but just some of the ways that they're different. So iliacs are big, so that's good for our long-term patency. It makes it a little bit more dangerous to intervene on these. If you have a perforation, bad things can happen very quickly. They are very tortuous, and sometimes we sort of forget this when we're just looking at an AP DSA. There's a lot of three-dimensional curvature of the iliacs that we're going to have to contend with, and we're going to have to keep that in mind when we're deciding about conformability of our destination therapies, either balloons or stents. And then obviously they are retroperitoneal, which is a big issue for safety, so we always got to be careful, especially when we're thinking about our adjunctive therapies. Some things that we may be able to push in the SFAs and below the knee, really are probably not the best choice for the iliacs. Luckily, especially when you're starting out, having to make all these decisions, there are a good amount of data to guide you, okay? And there's data in many of these different realms. So there's data on whether we should be treating these endovascularly at all. There's data on PTA versus stenting, on covered versus bare metal stents, self-expanding versus balloon expandable. Some, now mostly retrospective data on lesion modification and special techniques. And all of these data put together can help you make the best decision for your patient. And then, so the goal of this talk is just to get some of these trials kind of in your head. You don't have to memorize everything, but just so you know that you can go back and reference it, if a clinical situation comes up. So first of all, should we be treating these endovascularly at all? And I think the answer is resoundingly yes. So this is a very old study comparing surgical versus endovascular treatment for aortoiliac lesions. And we can see that the primary patency at 5 years for endovascular therapy is a little bit lower than direct or open bypass, so 71 versus 82%. But peri-procedural mortality is significantly lower with endovascular intervention, as is the average length of stay. So the endovascular patient stayed for 4 days, whereas the bypass patient stayed for 13 days. This is borne out in a little bit more recent study, the Bravissimo registry, which again, showed very good primary patency at a relatively long-term follow-up, 2 years. So almost 90% primary patency. And importantly, stratified by task A and B, so simple lesions versus task C and D, more complicated lesions, and did not find any difference there. This, among other data, have led societies to strongly recommend endovascular intervention as the first-line therapy for most aortoiliac disease. So this is from the ACC, SCI, and SVS also joined in making their recommendation. Everything is kind of a piece. If you think you can treat these lesions endovascularly, you're absolutely okay and supported by data to do that. Okay, so you finally decided after going through the literature that you will treat this endovascularly. What now? The first trial that we're going to go through is the Dutch iliac trial, which looks at PTA versus stenting. And so this is really a decision about your destination therapy. So can you PTA these lesions and leave them alone? We always like to leave nothing behind if possible. Or does upfront stenting strategy lead to better outcomes? And so this was really the definitive trial in this space. They randomized 279 different vessels to upfront stenting versus PTA with provisional stenting. Now, the important thing to know about this trial is that 43% of the PTA patients crossed over to stenting in the end, okay? So if you do choose an upfront PTA strategy, just be aware there's a almost 50-50 chance that you're gonna have to cross over and stent. That said, in terms of comparing the two strategies, intention to treat, at 5-year follow-up, there was no difference in primary patency between the two strategies. What this trial says, and then there was a little bit of data prior to this that suggested upfront stenting may be better, but I think this is so far the definitive word. It's okay to go in with an intention of a primary PTA strategy, but just be aware and have a low threshold to cross over to stenting. Okay. Okay, so you've treated your lesion, you decide you do need to stent, for whatever reason. What kind of stent should you use? So we're going to go over 2 trials that compared covered versus bare metal stents in the iliacs, and then we'll look at 1 trial that compared self-expanding to balloon expandable. So the COBEST trial is one of the best-known trials comparing covered to bare metal stents. 125 lesions randomized to a covered stent, which was the Adjunctive V12. Which is sort of an earlier covered stent that I think is only really used in Europe now, versus bare metal stent, both of them balloon expandable, okay? In this cohort, they had 77 patients that were followed out to 5 years. And at 5 years, it did look like the covered stent patients did better in terms of primary patency. Some of the other clinical endpoints, amputation, quality of life, there wasn't much difference. But at least in terms of primary patency, it did look like the covered stent patients did a little bit better. This was stratifying by the overall cohort versus more complex lesions. And it does look like there is an increased signal for efficacy in task D lesions, so more complex lesions. And I think that can make sense. You can maybe push your adjunctive therapies a little bit harder. You can push your post-dilation a little bit harder if you feel comfortable you have a covered stent that's going to prevent major perforations or major issues. A more recent trial, the Discover trial, which was released in 2022, looked at 174 limbs, common iliac disease only, and randomized to a balloon expandable covered stent versus bare metal stent. 6 patients did have to cross over. This trial was more equivocal. So there was no strong signal for improved efficacy in covered stents. Again, this is a more recent trial. You think there are some adjunctive therapies that have come online in the time between the COBEST trial and this trial, which may have influenced the outcome here. Whereas before, it was orthodoxy to say covered stents probably better, especially in complex lesions. This trial casts a little bit more into doubt. I think gives us a little bit more room to choose what's best for the patient. Okay, then thinking about self-expanding versus balloon expandable. We have the ICE trial. This is one of the biggest trials that we're going to include in this talk. So 660 patients randomized to a balloon expandable stent or self-expanding. The primary endpoint was binary restenosis, so looking at it with an ultrasound in 1 year. This trial overwhelmingly showed that the self-expanding stent patients did better in terms of binary restenosis compared to the balloon expandable. Again, some of the clinical endpoints, walking impairment, amputation, death complications, those were no different. But if you're just thinking about primary, primary patency, there is some signal that self-expanding stents do a little bit better. And it's really borne out across most subgroups here. So you can see to the left, the self-expanding is favored versus to the right. So older, younger, female, male, diabetes, no diabetes, the self-expanding really saw an advantage in all of these subgroups. In terms of lesion modification, there's a little bit less data. I think that there's a lot more coming online as we're seeing more and more IVL being used in this space. So in terms of orbital atherectomy, I think, again, this is not really a commonly accepted modality to use in the iliacs. There may be rare occasions when you might reach for that. This is some old data from the early 2000s. Sorry, I don't have the citation here. I'll fix that. But basically a small registry that showed, you probably can use OA safely in terms of dissection, no reflow, perforation, things like that. But again, there's not a lot of efficacy data, and I think, more and more we have a new tool that we know we can use safely in the iliac. So IVL has really taken off in this space. Multiple catheters we can use. It feels like they're coming out with a new one every 6 months with longer, bigger, more pulses, faster pulses. And we definitely have the equipment that's big enough to use even in the biggest iliacs. Although you do have to keep in mind some of the bigger IVL balloons will need a larger French sheath size. So there's some retrospective data on IVL in the iliac space, the IV-Iliac registry. So they looked at IVL alone versus IVL and stenting. They had a nice kind of rubric that the operator had to follow in terms of crossing over to stenting if the patient got IVL alone, and looked to really optimize the post-IVL outcomes. And basically, again, this is a registry study, but they did have very good primary patency at 2 years. So I think again, we need prospective data, but this is reassuring that IVL is an effective thing and can be used alone or with stenting. Just very briefly, we keep in mind when both iliacs are involved, or if there's distal aortic disease, there are multiple different special techniques that we can use in this space. So the kissing stent technique has been studied, where basically have bilateral access and you bring stents up, and a little bit like V-stenting in the coronaries. You do 2 balloon expandable stents, creating a neocarina, and that's been shown to be effective. If you only have unilateral disease, obviously there's some concern about plaque shift into the contralateral iliac, but there's been a little bit of study. You don't necessarily have to do kissing stents if the contralateral iliac is not diseased. There's also the CRAB technique. Again, this is usually if there's distal aortic involvement, and this kind of improves the hemodynamics down the 2 iliac limbs and creates less dead space in your intervention. And again, that's something that's been well described, and you can see all kinds of live cases and stuff where they use that technique. So in summary, and we're almost not going over time, there are a lot of different options for iliac disease. There's nothing dogmatic in this space. We can feel good that there's good 5-year patency for all types of interventions. A large proportion of patients will require a stent, but as far as we know, you're not going to take a hit if you do an upfront strategy of PTA. Covered stenting may be better than bare metal stenting, although, again, that brings a little bit into question, especially as you get more and more complex, more calcified, that reaching for that covered stent may be a good idea. And then self-expanding is probably better than balloon expandable when you have the choice. And that's probably relates more to the conformability to this complex anatomy. So again, a lot of these recommendations, these guidelines are a little bit outdated, but a lot of these recommendations are reflected in SCI guidelines. And I will just quickly go through what we did in this case. So we did a PTA. We IVL'd both limbs here. And when we took a picture of the right common iliac, we decided that the more proximal stenosis really was significant. So we ended up doing kissing stents with 2 8.0 VBXs and got a very very satisfying result here. And the patient did great and continues to do great. So thank you so much. I appreciate your time, and thank you to Raman for having me.